Okay, well, let's get started. Hi, I'm Maria Margaglione, Programs Director here at DBSA, and I'm pleased to introduce this important session on misdiagnosis and taking charge of your care. I'm joined by my colleague, Hannah Zeller, and two of our esteemed Scientific Advisory Board members, Dr. Roger McIntyre and Dr. Mark Frye. Dr. McIntyre is on the DBSA Board of Director and chairs our Scientific Advisory Board. He is currently a professor of psychiatry and pharmacology at the University of Toronto and head of the Mood Disorders and Psychopharmacology Unit at the University Health Network in Toronto, Canada. Dr. Frye also sits on DBSA's Board of Directors and is Vice Chair of our Scientific Advisory Board. He is a consultant in the Department of Psychiatry and Psychology at the Mayo Clinic, where he is past chair from 2010 to 2020 and is recognized with the distinction of the Stephen and Shelly Jackson Family Professorship in Individualized Medicine. That is a mouth twister. Thank you both for joining us today.
Great to be with you, Maria, and thank you, Hannah. And Mark, nice to see you.
Great to see everybody.
Just a couple pieces of housekeeping for our audience before we get started. Maria and I will be asking questions throughout the session, but if you have questions that come up during the session, please feel free to use the Q&A function at the bottom of your screen to ask questions for the doctors, and we will be sure to get to them by the end of the session. And with that, I'm going to turn it over to Maria to start us off.
Okay, thanks, Hannah. Just quick, what today's objectives are. We're going to talk about, we're going to learn how mood disorders are diagnosed, understand common mood disorder misdiagnoses, and learn ways to take an active role in our treatment. If anybody was present for Wednesday, one theme that kept coming up is communication with your providers. So I imagine that will come up again today. Roger, do you want to start us out on how is a diagnosis made?
Yeah, that's such a great starting point, Maria, in the conversation, because that clearly is the part that ignites the next conversation. How do we help people? I always like to start off with how it is not diagnosed. It's kind of a peculiar way to start off, but I want to start off that way purposefully, because I have noticed over my career that many people have arrived at the diagnosis in ways that it should not be diagnosed. What do I mean by that? Well, it's not diagnosed by an MRI scan, going for a brain scan. It's not diagnosed by going for a psychological test. It's not diagnosed by a blood test. And I want to start off with that because that's the future. We hope, Mark and I and many others in the field hope that is the future, that we'll have one of these technologies that'll help us, but for now it is a clinical diagnosis. What that really means in the speak is that it means you need to speak to a care provider, and a care provider will take a careful history. Now, there is a criteria that is well accepted that defines bipolar disorder, and we should say bipolar disorder is plural, so there's different types of bipolar disorder, and that is in our textbook. We have a criteria. And a skilled clinician, and this could be a nurse, could be a physician assistant, could be a nurse practitioner, could be a physician, a psychiatrist, many people broadly defined who have comfort in this area would take a careful history, and the history would attempt to gather the symptoms of the diagnosis, which is well laid out in the diagnostic criteria. And also what the clinician will do is really take the time, put the pen down and take the time, understand the kind of long-term course of this. This is really important, Maria, because bipolar disorder isn't something that happened today. It's something that affects people throughout their life, and trying to figure out, when did this all start? How many times have you had problems with depression? What type of treatments have you had? And what happened when you took them? What about your family? Does anyone, taking a good family history, as well as, in fact, learning more about other problems people have, because bipolar disorder is a condition that often coexists with other conditions. So what I'm getting is that we will often ask people to complete a screening tool, but a screening tool doesn't diagnose the condition. It kind of raises your suspicions or lower your suspicions. And the clinician will say, let's roll up the sleeves, let's sit down, let's talk about your history, when you began, your childhood, let's talk about your medical, so on. And that's how the diagnosis is arrived. So it's effortful, and it's one that should be taken very, very carefully and thoughtfully.
It's a great answer, Mark. Do you have anything to add to that?
I would underscore a couple comments that Roger said that really need to be emphasized in the context of being proactive and getting providers that are attentive in their listening skills to really optimize outcomes and get people back to doing things that they want to do. You know, Roger had referenced screening questionnaires, and those got started, I don't know, about 10 years ago. And as he was noting, there were two phenomena that were happening that just didn't seem really right to clinicians. Number one is the questionnaires might be filled out beforehand, which is great. Don't get me wrong. That makes a much more efficient use of our time. But I often found that the questionnaire for many would be, okay, we have our answer. Next item, where in fact, the questionnaire, whether it's positive or negative, I think just really fine tunes the next really critical and important step, as Roger referenced, that being an interview. We don't have the technology that's part of our everyday clinical practice where a blood draw or a brain scan might say, yes, this is bipolar disorder, or no, this is someone that doesn't need a mood stabilizing treatment. And lots of active research in the field, and our hope is one day that will be clinical practice. But now it's really taking a really careful assessment of what we call longitudinal course, looking for key symptoms or milestones, always emphasizing the benefit of getting information from people who are loved ones and are part of the family or part of the community in a way that we might not have in a single visit in the clinic.
Yeah, that was another theme was it's a snapshot. We're just seeing a snapshot every time someone comes in, and there are so many variables, so many things affecting it that a clinician is not able to see. And if the patient doesn't report it, it's how do you know? So, well, that's great. What are you two looking for to make a diagnosis of depression?
You want to go first, Mark?
Sure. You know, there's no sort of hard, fast rule, right? I mean, we have general criteria that we look for, and these were established by clinicians and researchers across the country and across the world, and those are really helpful guides. Obviously, what's critical for the depressive phase of illness is we look for a sense of being sad, blue, down. This is not a bad day. This is a series of days where symptoms of sadness and feeling down are significant. And most importantly, they really make an impact in someone's life, and someone's quality or someone's function. The second criteria is really looking at a loss of pleasure. And that one is pretty nuanced as well, actually. I don't think it's an all or none. And so invariably, my questions start to look at a sense of joy, perhaps to fullest capacity, or does it seem blunted in some way? You know, those are the main features. There can be a lot of other symptoms that we look for. I'd be curious as to Roger's thoughts. The reason I paused, Maria, with your question is, yes, many individuals living with depression will recognize immediately depressed mood or lack of joy, but not everybody. And there's a very clear research pattern that quite commonly men might not really key into being depressed or having a loss of pleasurable activities. Maybe it's more irritability, or maybe it's more headache or back pain, or more problematic drinking that would not have been there otherwise. So yes, we look for conventional symptoms that we know are very common, but we need to be broad in our initial scope, recognizing that depression can present differently in patients and in a single patient differently over time. Mm-hmm. Roger, I'm sure you've seen that constellation of irritability and headache and problematic drinking as a presentation for depression.
Yeah, that's right, Mark. I have, and I like Mark. I like the way you answered that, because in my years of doing this, tens and tens and tens of thousands of people I've had the privilege of meeting who live with bipolar disorder. Sometimes they almost want to ask me, how come you're asking me so much about depression? I'm here to find out if I've got bipolar disorder. And I say, exactly, let's talk more about your depression. And the reason being is that when you have bipolar disorder, depression, I mean, mania is what defines it. And of course, hypomania is looks a lot like mania, a little briefer in duration. And at least in the moment, it may not appear as severe as mania, but most of the time that people live with the illness, it's the depression that really is the enemy of the state. It's what actually first presents when they're in their teens or 20s, usually, but could be younger, could be older. And I ask all people, how many episodes of depression have you had? And was there a seasonal pattern to it? And what happened when those depressions were treated with antidepressants? And they're like, let's take a time out here. I'm here for mania. How come you keep asking with depression? I said, yeah, exactly. I'm asking you about bipolar disorder. And so that's, I think, a really important point. And I think, Mark, you'd agree with me that, and if in fact someone does have depression, every patient should be asked about manic or hypomanic symptoms currently or in the past. And if they never had them, okay, great, that's great. But that doesn't mean we take our eye off the ball. Like 5 years from now, 10 years from now, if depression comes back, I'm going to ask it again. And they're going to say, you asked me this before. I say, yeah, I'm going to ask you again. Just because sometimes it comes later, a little bit downstream. Now, over the years, Mark, I've been thinking about this, and I've been sort of stepping back and trying to think to myself, what's the best way, kind of almost like a little kind of a slogan or a little bumper sticker thing to kind of remember this. And I came up with what I call the 4 A's. And so I always ask everyone to refer to me about the 4 A's. So what do I mean by that? So if someone comes to me and they say, I'm really depressed, I say, do you have anxiety? Do you have agitation? Are you angry and irritable? Do you have a lot of attentional problems, almost like ADHD? And if I hear someone say, Dr. McIntyre, I'm really anxious, I'm agitated, I'm angry as heck, and I can't focus, I can't pay attention, does that diagnose bipolar? No, but that gets me really suspicious. Start getting me, and so I think with this, Mark, almost like, like the big screen TV, those nice pixels. For me, bipolar disorder rarely comes in as a black and white portrait. It's trying to get the pixels on the screen, and all this information Mark and I are talking about is filling in the pixels of the picture. And over time, the picture starts to appear,
What I like about the 4 A's, Maria, is recall that none of those A's referenced depression or loss of joy. And yet looking for those constellation of symptoms makes a lot of sense. We will have times where individuals, for whatever reason, may not be very able to communicate their mood state, how they're feeling. And that is absolutely okay. I usually move on to probably what are more critical questions. So I like Roger's 4 A's. I haven't put a little funny name to it, but the 2 things that I really focus on is sleep and how sleep change impacts energy. And again, nothing about this is depressed mood or loss of joy, but very often individuals living with bipolar disorder, the loss of sleep is associated with surprisingly not being tired or actually being energized, or kind of a wired and tired feeling at the same time. Yeah. Where in fact, most individuals living with major depressive disorder or unipolar illness, a lack of sleep really drives a sense of feeling exhausted. So right there is a pivot point. Again, not 100%, but when I see someone really describing less sleep and an increase in energy, or at least not feeling tired, that starts to then really focus my sets of questions more on bipolar illness. And I'm going to take Roger's 4 A's and incorporate that as a next scale. But I think what you're really hearing is when we're trying to make a diagnosis of the depressive phase of bipolar disorder, very often we focus on things that have nothing to do with depressed mood or loss of pleasure or anhedonia.
That's a nice point. What's also interesting, Mark, about our conversation so far is that I think if people turn on Netflix and watch a movie and the director's depicting how bipolar might present in a kind of Hollywood sense, nothing that Mark and I are talking about is how bipolar is presented in Hollywood. In the sense that Hollywood would present, and I think what they're doing is, of course, it's Hollywood, but they're presenting what is sort of more kind of a more familiar presentation of bipolar, where someone's very overly energetic, they're elated beyond belief, in fact, losing touch with reality, spending lots of money, making very silly decisions, very poorly thought out choices and things like that. And that clearly is mania. But what we're talking about is, how does bipolar really present in the real world? Like, how does it really look? And yes, people can certainly have those more sort of so-called textbook, or what I kind of introduced as more Hollywood kind of presentation, but that's how it's often presented. But in reality, what we see is more irritability and that sleep alteration Mark talked about, with what I kind of talk about these 4 A's, that real kind of very unpleasant feeling. And a lot of people will say to me after, I say, I really think you have bipolar disorder. They say, really? I don't spend lots of money, or I don't actually feel like elated and grandiose. Isn't that how it presents? It can, but not usually. And so I think what Mark and I are talking about is the most common way it really presents. And I think that's why it's missed so much, because people don't even think about it. They sort of think, oh, I got depression and some anxiety. I need Prozac. And that's a very common kind of unfortunate conclusion that takes place.
Well, and as you two have been talking, I'm thinking of a couple different things. One, the loss of pleasure and the nuance, going just a little bit back to what you were talking about, I think, Mark. To someone who has never experienced pleasure, this is normal, and so nothing is wrong. And so why would I think that? And on the other side of the mania, well, we talked about this a little bit on Monday too, of like, well, I feel really good. I'm finally not feeling low. Why would I say anything? And so, yeah, to your point, Roger, on the Hollywood bipolar disorder, of that has to be the psychosis part of it, or some type of extreme in the most, well, the spending or the sex, etc. So one other question I have that's related to this is, and this is kind of hitting the for friends and family, a question for friends and family, when we hear he's just so negative. It's a personality thing. And it's not. How do you explain to family, or even to people who, no, that's just how I've always been. This isn't depression. This is how the world is. How do you explain to them the difference?
Yeah, I think that it begins with, first of all, having an open-mindedness to all considerations. And I think that in my experience working with people, that there's nothing other than positive to just remain open-minded. We all have our biases, only a few of them we're aware of, but just be open-minded and be open and flexible. Second is that I think, to your point, I think having different vantage points, not just the person living with the condition, but those, carers, loved ones, friends, family. And there's not, as they always say, that there's one truth and there's endless versions of it. And so there's not, there's different versions of the truth. And so it's good to sort of put all those truths together. And then thirdly, I think, just to be, I have more of a tactic that a clinician would do to maybe address that question. Nothing too fanciful or too creative. It's just taking a good history. And because when someone's depressed, when someone's in their, say, their 20s or 30s or whatever, 40s, 50s, they have depression. One of the aspects about depression, the way it affects the mind, is that it leaves the mind quite inflexible. We have very black and white thinking. It's all good, all bad. I'll see people come to my office and I'll been on 10 or 20 prior treatments, and I'll say, oh, of those treatments, did any one of those work a little bit? No, none of them worked, not at all. And then I find out from the med chart, that's not quite the way it was recalled from other people. So I think there's a sort of black and white, and that sort of negative, there's a sort of very negative recall. And I met somebody not that long ago, and I asked them, I said, they were in their 40s, and I said to them, when did your depression begin? Oh, I remember exactly when it began. I said, okay, a long time ago. I said, okay. He said, it began when I was an embryo. And I got the point. I said, I think, okay, this is going on for a long time. So I think you take a good history, and not always, but usually it's the case that there is, in fact, evidence that there may have been traits in their personality. Maybe they're more anxious. Maybe they're a person a bit more fearful, or a person who may be, more prone to experiencing aches and pains, and may have seen the doctor more often as a kid. But really depression, and Mark talked to this when he kind of it brought that quality of depression, it's quite different. And that usually then it changes their life. And you can sort of say, oh, I was functioning at this level, then in grade 12, this happened, or when I was a sophomore, this happened. And if you take a careful history, you can often find, we call it trajectory, when the trajectory changes, when the life course starts to really change. But that's not going to be arrived at with a 30-second med check visit. That's going to be arrived at with taking the time. And so that's a tactic that we try to suss that out. But I'll leave it to Mark. I don't know, Mark, maybe Mark does something differently.
I see it that same way. You know, Maria, I think the tone of how you gave your example, you know, oh, it's just, you know, personality. We hear that a lot. And I think this is where DBSA has been so invaluable to really provide education for family members and loved ones that I think oftentimes that, oh, it's just a personality. I really take that to mean there's a lack of awareness or lack of education, and it's a teaching moment, right? It's a teaching moment for two reasons. Just the tone of your voice, you can see where there's a criticism to that, and there's kind of a minimization, and that's something we can really educate on, how destructive that can be to the individual to hear that tone. But more often than not, providing education about illness and symptoms and how they might progress in a way where they can really start to see, yes, this is in fact different. And Roger's example, you know, maybe there are some personality pieces that are there always, but when the stressor comes along or the episode emerges, everything is really magnified many-fold. And I think providing a place to really have a forum for education for family members to really become more knowledgeable about what they're seeing, that's a great role for DBSA. And I've found providing that space and that education, we hear less about, oh, it's just a personality disorder, and there's an awareness, right? And that helps overall with treatment and recovery.
Agree. And I think as in the past 10 years, I mean, we still have a long way to go as a society, but there is a little bit less stigma now and a little bit more awareness and a little more openness with people younger than me on seeing therapists, and I have this diagnosis. And so this is starting to happen, at least that I've noticed, and I'm sure you all might be too.
Very much so.
I love this point though, just to share it, like, because we tend to self-stigmatize. So I think as long as we can provide that education alongside, we can stop that kind of stigmatization that people might be feeling when they first receive a diagnosis, because we know those feelings can be so complicated for folks. For sure. I think we also wanted to talk a little bit, I know we touched on screening at the beginning of the conversation, but I think we specifically want to talk about screening for bipolar disorder in particular. And so I was wondering if you could share a little bit more about from your perspective as clinicians, how effective that is, and what our consumer audience should know about screening for bipolar.
Well, there are a number of screening instruments. The one that DBSA was instrumental in helping develop is the Mood Disorder Questionnaire, or the MDQ. I suspect there probably are some other ones, but my sense is that's the one that has the most widespread recognition. And they're very helpful and very valuable. And those screening questionnaires really are keying into, have you ever had, and it's common language, it's not medical terminology, but it really gets at signs and symptoms of elevated mood or mania. And the next set of questions say, okay, if you've had some of these, do they co-occur? Do you notice them at the same time? And lastly, a question about, does it negatively impact what you're trying to do? And to our earlier comments, I find these very valuable. I was a little surprised when they first came out, because they tended to be, I have my answer, we're done. Where in fact, that's really not what a screening questionnaire is about. It's a place to get started. So those questions and how they've been answered immensely help Roger, many clinicians, I would say, fine tune the questions that we might be asking in our interview to confirm, yes, this is bipolar disorder, no, it's not. Important to emphasize, there are a number of other conditions that will non-specifically screen high on that questionnaire. Agitated depression, individuals perhaps in a withdrawal related to substance or alcohol use, borderline personality disorder, all of these can non-specifically, screen high. And again, it's helpful because it just helps the clinician secondarily fine tune the questions they're going to help, or the questions they're going to ask to really tease this apart. So I think it's a very important part of my practice, but it's the beginning, not the end.
Yeah, I agree with all of that. We at DBSA are interested in, of course, all mood disorders, not just bipolar disorder. And screening for major depressive disorder really took off about, not quite 20 years ago, but we'll just say almost 20 years ago, a tool that many have heard of called the PHQ-9. And if I was to look around the landscape, which area does this the best? Who screens for depression the best? Well, I don't know the answer, but the one that comes to mind for me first, may not be the right answer, is in women who are pregnant. Just about every single organization recommends that pregnant women be screened for depression. And that's just part of the standard workup. But we don't have routine screening for bipolar disorder recommended by a lot of organizations. And this is something we have got to do better work on. Now, we have about a half a dozen screening tools for bipolar disorder, and they have their different characteristics and all of that. The MDQ, as Mark was saying, is probably the most recognized, validated in many different languages and things like that. And there's another one called the Rapid Mood Screener, which is relatively newer, that's been validated. And really, in fact, the part for me that's always been kind of a call to action is in the field is what we call the knowledge practice gap. What is our knowledge and what do we actually do? And we did a survey. We did a survey last year. Here's what we found out. We found out that over 85% of clinicians around America know at least one screening tool for bipolar. That sounds really good. Next question was, do you use them? And only about 25% they said they use them. That's a gap. That's a huge gap. So we've got to close that gap. We can't close the gap till we figure out what's the barrier and what would possibly enable it and all that kind of thing. But I think to Mark's point, I think there has been a little bit of confusion on what screening tools actually do. And I think some people kind of threw the baby out with the bathwater when it came to screening tools, because someone with post-traumatic stress or alcohol substance use or an eating disorder or whatever the case may be, may have what we call a false positive on these tools. And that, I think, has kind of left people a bit of a bad taste in their mouth. They kind of threw the whole thing out. And so what we're trying to do is we're trying to maybe get the message a little more clear that screening tools don't diagnose bipolar disorder. They increase or decrease your suspicion, but they don't diagnose it. And we see it as the starting point in the conversation with someone who's presenting with depressive symptoms. And so it is a really, really important point, because I think, and Mark, I did see your thought on this. I think there's been a little cynicism with screening tools. And I've heard across the country, people think that bipolar is overdiagnosed. I think overdiagnosed. And how can it be overdiagnosed and underdiagnosed? This is on the front page of newspapers. This is not just some academic, sort of point in the classroom. And I think there's a bit of cynicism, and cynicism has many authors. But I think as it relates to screening tools, I think that many clinicians got quite frankly put off by the fact that they had understood the screening tool was meant to be a diagnostic tool, and it's not.
That's probably where the overdiagnosis is coming from. Roger brings up a good point about the PHQ-9, and DBSA is for lived experience with mood disorders, emphasis on plural. Here's a really good example of where the everyday clinical practice knowledge to clinical practice is better in major depressive disorder. And that PHQ-9 score, what's very interesting about this is that has been well accepted all over the world. And I think so well accepted that it's starting to become part of the electronic health record, where I suspect many individuals who are getting their care from their primary care provider, or to Roger's example, their obstetrician, are starting to really become familiar with that and might actually even be able to see longitudinally how their PHQ-9 changes when they're in for their annual physical or a well baby check or coming in for some sort of infection. That's impressive. That's really taking mental health knowledge, putting it into the electronic health record to really make an investment in the practice, have more data that healthcare providers can be greater, can provide greater precise care in what they want to do. And knowing symptoms of depression is really valuable. That is non-existent for bipolar disorder. So one of the areas of very focused effort, and I know Roger's working in the space, is how do we actually, what's the equivalent of a PHQ-9 for bipolar illness, and how do we really make sure that's capturing what's meaningful in people's lives? Next step, how do we get that integrated into their electronic health record so it's easy, simple to do, and we can follow it over time? That's an important project to get forward.
Well, and we're starting to touch on the next question that I was going to ask was on delayed diagnosis. What we're talking about seems to relate to why there might be a delayed diagnosis. Can you talk a little more about a delayed diagnosis?
I can start. This is where DBSA has been critical in getting the research done, and I know DBSA will be critical in making changes to improve this, but we see delays, and those delays tend to be about a decade. And this is really through survey data with individual members of DBSA, or the first survey was actually done when it was the MD, or the National Depressive and Manic Depressive Association. And it looked like there were delays. Now, we don't know exactly what the delays were about from those survey data, but I'm sure Roger as well can comment. And I'd say most often, in particular for women, the delay was not recognizing mania or not screening for mania or hypomania. Now, part of this might really be the illness itself. We know that for women, there can be one, if not multiple episodes of depression before that defining manic or hypomanic event, and hence the name change to bipolar. But I think what's probably more common is mania, hypomania is never a reason why someone comes to an outpatient practice for an evaluation. It's depression. And so maybe it's a limited period of time to do an accurate assessment, but I think oftentimes the mania gets missed, hence the delay in diagnosis. I would say for men that can happen, but what is probably more common is maybe a misdiagnosis related to schizophrenia or an alcohol addiction. And again, it's kind of the same thing, is that the core mood symptoms haven't been adequately screened for. I can't tell you the number of times working with an individual who has a major milestone of achieving sobriety, and then the mania becomes very clear, and it probably was there all the time, but wasn't the focus of attention in a way that it needed to be. I would really be interested in DBSA members kind of thinking of ways to use Roger's term, to bridge this gap. The thing that's really heartbreaking for me is if we see a 10-year delay, that means it's a 10-year delay where the really life-saving treatments aren't being used. Lithium is a really good example of that. And you can really start to appreciate how that might be if the misdiagnosis is major depression and there's every antidepressant getting prescribed, or it's the misdiagnosis of schizophrenia and every antipsychotic is being prescribed. That's heartbreaking. We have really good data highlighting that if we intervene early, we probably get a better outcome. And so that misdiagnosis and that 10-year delay has implications, no question.
Yeah, I agree with all that, Mark. And you know, what's interesting is that when I think about the delay, I think that there are some aspects about this that are not modifiable. And there's some facts about parts about this that are modifiable. Now, good news, most of them are modifiable, but what do I mean by non-modifiable? Well, I'm going to blame Mother Nature for this, because the most common initial presentation of bipolar is depression. And very often the hypomania or mania won't declare itself for a year, 5 years, maybe 10 years later. So to be, I guess, fair, that wouldn't be necessarily a misdiagnosis, or in the sense that the clinician, the perfect clinician working with the perfect history would call that depression. That's the right answer, but it's not the right answer. But they can't see below the surface. They wouldn't know that mania is going to come later. So that's something that's a different scenario. That's why it's important to have repeat screening for bipolar, even if 5 years ago, 10 years ago, you screen negative. The part that, I mean, most of this is modifiable in the sense, I think that it's true. I think that when people come to the clinician, they tend to come usually in a depressed state. And I think that bipolar is often not even screened. They're not even asked about it. That's one part. Secondly, I think, and this is something I've witnessed firsthand right around the world, is that people don't necessarily understand the multidimensionality of bipolarity. In other words, we talked about, euphoric or elated symptoms. Yes, that's true, but those symptoms Mark and I talked about are more common. So in other words, having a full understanding of the various ways that bipolar can present. And then I think thirdly, I think it's in part kind of the nature of bipolar symptoms. Survey after survey after survey has shown that when someone has bipolar disorder and they've had a prior history of hypomania or mania, this is not a theoretical mania or hypomania. It's been documented in the health record. They were admitted to hospital. They had a manic episode. And then they see a doctor later or a nurse later. They often forget to reveal those manias and hypomanias. It's like they just vanish from their memory. They just forget. Now, for some, there's reasons why they don't want to talk about it. That's a different issue, but people just forget. And then I'll say, by the way, I'll take a very thorough history and say, nope, I never had that, never had that, never had that. And then it often happens halfway through the consult, I get an email, oh, you're seeing my patient today. Here's some additional information. Oh, perfect timing. And then I find out, I open up the attachment. Oh, you were admitted to hospital 12 years ago. You were in hospital for 3 weeks. So I forgot all about that. You're right, I was. So that's a mystery to all of us why that happens, but there's something about memory and recalling these things. So I think, again, it's about taking that careful history, but I think those factors add up to why this diagnosis is like that. One final sort of, if I could say one final aspect about this, the reality about healthcare nowadays is that the visits are very brief. And many people will see their care provider for 10 minutes, for 5 minutes, for 6 minutes. Mark, you may be different than me. I can't make the diagnosis of bipolar in 10 minutes. Sometimes I can, but I usually can't. And so the healthcare system and this kind of perverse reimbursement system we have is reinforcing very quick visits. And that's not enough to get really into the weeds. So that's part of it as well, but I just wanted to bring that up.
Yeah, as you're talking, I'm wondering about, there could be forgetfulness, but I wonder if it's, have there been consistent, are we talking about it in the same way? Are we talking about behavior versus, the DSM says it this way, but someone else experiencing it may not see it in that exact bubble. I don't know, is there any thought on that, the communication piece? Same language?
You mean in terms of how I make up, just want to understand, so the way it's depicted in the DSM, you mean, in terms of in how we understand it?
Well, sure. For your example of someone coming in, they forget about that mania. Do they have a different language for it than the provider?
I think that's a really nice point. I think part of this, quite frankly, comes down to what we would just call medical literacy. I mean, why would anyone have the, before I became a psychiatrist, I didn't know any of the language of psychiatry. I wouldn't have known what a mania was or a hypomania was. And if someone said, you ever had mania, before I became in the medical profession, I wouldn't even know what that even was. And so I think we're guilty of making assumptions about people's medical literacy. And that's not meant to patronize people. I don't know anything about mechanics. I know nothing about engineering. I didn't know this vocabulary before I became a psychiatrist. So why would they? And I think a lot of times we are guilty of using medical jargon. So we're not quite on the same page, using medical vocabulary. Some of it's kind of probably a little bit too esoteric and all that. But I think that's part. So I think medical literacy is part of it. And I think secondly is memories are funny things. Memories, like I said, that example has happened to me so many times where I'll say, oh, we talked about if you ever had a hospitalization before for psychiatric reasons. You mentioned you didn't, but I see here in the chart you've been admitted 4 times. And each time you've been told, it says here by the attending physicians, you were manic. The person would say, oh yeah, I forgot about that. And they're not trying to, play games or not, conceal, they just don't remember. And that's just the mystery of our memory systems and all that. In some cases, there's reasons why people may be embarrassed or there's stigma. And here's another situation that commonly happens. Bipolar is heritable. And a lot of people who have bipolar disorder, most of them know someone in their family who has another mental illness. And understandably, this happens a lot where I'll see someone and they have bipolar disorder and their mom or their dad had bipolar or both had bipolar. Mom and or dad had a real bad time with bipolar disorder. And the last thing they want to have me confirm is they have what mom had. And so I think that plays into the dynamic sometimes too. And that's very understandable. You have to approach that very empathically.
This summer I've had a family member with a medical condition that had them going in and out of the emergency room in the hospital. And as a physician, I kept thinking to myself, I am tracking most of this, but not really all of it. And I kept thinking to Roger's comment about health literacy. Healthcare, the good news is there's such technological advancements and neuroscience understandings of illness that we know more than we ever have. And that's exciting. But how do you actually take that language and translate it in a way where the community can really understand? We don't do that very well. And we have to start developing language that is less medically scientific and more community-based and understandable, or all of these advances that we're going to have will have no meaning and will not make meaningful impact in people's lives. But I just kept thinking, and this was not in psychiatry, but there were so many complicated pieces, and I, felt like I was having trouble advocating for my family member. And I can't imagine if you didn't have that level of literacy, how scary it is. And so I think having some humility as to what we're trying to get accomplished is important. And we need to be better stewards in talking a language that everybody understands. Now, then both you, Maria, and Roger referenced this. There's a speed to going in and out of the hospital that just is a whirlwind, and it can make you dizzy. And I'm not sure how we address that piece. I think that probably is more interacting with our legislators and our community leaders. But I think trying to be mindful that the science is advancing, and that technology and that language, we need a translator, and we have to be better translators, or all of these advances will go unrecognized or unutilized. And we just can't have that.
Yeah, and I think also this is so well put, Mark. And I think where there's populations or so-called subpopulations within our broader population where this disconnect on language is even more an issue. And I'm thinking about African Americans, our Latin American communities, indigenous communities, and a lot of people who immigrate to the US or immigrate to the Western countries from, say, so-called Eastern countries or Asian countries and so on. They have a different way they communicate. their distress. And these things are influenced, of course, by language, vocabulary, culture, and so on and so on. So I think where our literacy, our vocabulary in describing the condition is really needing improvement is in those areas. And study after study after study shows that if you are African American, when compared to, for example, Caucasian American, you are even more likely to be misdiagnosed, even more likely to be on, in quotes, the wrong treatments, et cetera. So, and I think there's a lot to that, but part of it relates to different language that we're using.
Yep.
Well, you actually walked right into the next question. Can you talk a little more about that, especially within BIPOC communities, that misdiagnosis, and maybe how can clinicians do a better job or have a better understanding, or what needs to change in this area so that there isn't that misdiagnosis?
You know, it would be incorrect if I was to say there's just one solution, and I think it'd be naive and frankly silly to even assume that. There's not one solution to that, but I would say that to the extent possible, to try to be attentive to, cognizant of your potential biases. Let me give you an example. So a lot of our people who are joining us are taking a class of drugs called benzodiazepines, which are anxiety pills, like Valium type pills, okay? And so Valium pills, that category, is still one of the most prescribed medications in all of medicine. And we did a study in Florida, and we did the same study in Taiwan, because I wanted to see if this was a culture or a national thing or whatnot. What we found was if you're a female and you go to the care provider, if your care provider is a male, you're more likely to get the Valium pills. Mummy's Little Helper, they used to be called. If you're a male and you go to a male prescriber, you're not likely to get the same Valium pill. So we have BIPOC, we have gender biases, there's economic biases, there's all kinds of biases that are playing in. And look, this is not something that can be overridden with a slogan, just say no to drugs. It's not going to be quite like that. But I think you start with recognizing we try to be cognizant and try to maybe be contemplative about it. And then that's the first step, I think, towards a kind of more balanced and open-minded assessment of the issue. So it sounds very basic, but I happen to think that, like a lot of things, the basics aren't done and the basics need to be done. We can get in, and I think more sophisticated approaches come later.
Yeah, I would agree. I would say that is priority number one, is to really be more aware of bias, your bias. And this is where every single person has a bias, and just taking the time to pause, reflect, and try to be more meaningful in your questions and your interview technique as to how you make that diagnosis, right? This is actually where some of the screening questionnaires or more structured interviews might actually help reduce bias and get the right diagnosis. A lot of the work, this is primarily in bipolar patients of African ancestry, when it was a rushed evaluation. For example, one that might be in an emergency room. Emergency rooms are not places to stay to do a comprehensive diagnostic evaluation. That is not the purpose of that footprint of a healthcare center. The purpose is, does this person need to come into the hospital, yes or no? And if yes, let's move. Oftentimes we see an incorrect diagnosis in the emergency room that under closer inspection, more time, and more structured questions, we can get the correct diagnosis, and in this case, bipolar disorder. I think another variable that is going to be important for all of us is we can address our bias and be better stewards and have structured questions to help reduce those misdiagnoses. Probably one of the best strategies we can do to really address this long term is to have more clinicians of color actually doing the work. And that is another way to really have the footprint of the clinical environment have more diversity, inclusivity, and I would think that that would actually be very useful in directing more system bias.
And knowing that there's underrepresentation in research participants, there hasn't been hasn't been diversity within that. I think, you know, the last topic we'll get into before we start taking questions, diagnosing children. And, you know, there's split thought on that. Can either or both of you talk a little bit about, Hannah?
Actually, there's a great question in the chat. I'd love to kind of pair. We know diagnosing children can be challenging. I think this member who's in our audience asked a really great question. What are your thoughts on Gen Z's take on mental health and their openness to share that on social media? Do you think this will continue to destigmatize mood disorders? Or like alternatively, could it be harmful because it's encouraging this self-diagnosis, and it could be on some level maybe potentially glamorizing these conditions? So kind of two big questions on the table about the challenge of diagnosing kids, and then in particular looking at the social media literacy we have around it now and what that means.
Well, I'll take a first crack at the first one, that being the pediatric or youth or diagnosing bipolar in young people. And I mean, young people, I'm a young person, so I don't think we're talking about me. We're talking about youth, which usually means under the age of 18. And I think that's really two conversations, post-pubertal and before pubertal. Those are kind of two different youth, if you will. And I don't even know Mark's views on this. So Mark, I'll just lay it right out here. I take the unequivocal view that bipolar can affect youth, post-pubertal and pre-pubertal, unequivocal. Second is pre-pubertal, that's not very common, but it could happen. And that diagnosis, in my view, should never be made unless that pre-pubertal child is seen by an expert in that area. There's a few around the country. Post-pubertal bipolar, that's not that controversial to me. That's actually close to the modal age of onset of bipolarity. So I think it really is the younger people we're talking about, like pre-pubertal. So the field, you're right, the field, and I have to react with genuine perplexity because we have many people in our field who don't agree. They don't think bipolar affects youth. I unequivocally believe it does. And the evidence, in my view, is very compelling. And again, I've had people approach me over the years. They'll say, oh, I got this 1-year-old in my practice. I want to get bipolar. Okay, I don't think that's what I'm talking about. I don't think bipolar in a 1-year-old who's still in diapers, okay? I'm talking about an 8, 9-year-old or 7-year-old. And again, that's a diagnosis, in my view, that's not very common. It can happen, but that I would reserve that diagnosis to someone very expert in the diagnosis. Mark,
I think we agree on 99% of that, Roger. And I'll try to bring in the question as well, Hannah. So my opinion, based on really in the field for a long time and really collaborating with national and international leaders and people in this space. I'm an adult psychiatrist. I would agree with Roger. I think it is not common. I probably would use the word rare. I think it is just not something that most psychiatrists are going to see. And I would argue probably a good handful of child psychiatrists. I agree with Roger with regards to thinking about adolescence. And I think we have very good studies done at UCLA and Pittsburgh. If that adolescent is having a type of depression where they get very sick very quickly, and they have psychotic symptoms, and they slow down like they're frozen almost, that has turned out to be a set of symptoms that's very predictive of ultimately having a diagnosis of bipolar disorder. Now, I think what's probably one point that's important to bring up, and maybe is addressing what naysayers are, just because you've made a diagnosis of bipolar disorder in a 13-year-old, it doesn't mean that all sorts of mood stabilizing medications and 5 or 6 treatments are going to get started. Absolutely not necessarily so. I've found that parents of children with bipolar illness are very astute in recognizing symptoms and are getting their loved ones in early. And it may just be that there's a more intensive surveillance of symptoms and how they're changing over time, or it may be more school support or a psychosocial intervention, but I don't think medicines are necessarily the case right away. I would feel, to address again kind of the naysayers, the person that's probably most useful in making that adolescent diagnosis. I'm okay, Roger's okay, but let's get a child psychiatrist in there who really has that training, who most importantly understands and has really studied the developmental milestones of how we age and what is normal, what is not normal, and have the clinician that has that experience in really assessing family dynamics and environment weigh in on the likelihood of that. I think with regards to social media, I think this can be a powerful tool for good. I really do. The detraction is when it is used for bad, it is terrible. And I don't have an answer. I'm really just invigorated, frankly, to see the youth so comfortable with that media, and the potential is enormous. I just don't have a good answer for how to mitigate when things go terribly wrong. And this can be, precipitating depression, precipitating suicide attempts, contagion aspects of it. So, and I think, to the question from the audience member, there's something incredibly appealing about this, but at the same time, we talk about sort of content moderators. I don't know how you do that in a way that still maintains the good, but provides a safety net when things can go terribly wrong. And I think we're all aware it can go wrong often and with tragic consequences.
Yeah, I like that phrase, Mark, content moderators. That's sort of where I've landed on this. I've been marinating this one for a long, long time, the social media question. And I think that although it would be certainly, it would fit neatly into a bumper sticker to say that social media is bad or social media is good. Bumper stickers are very effective because they get the message across, but I would argue it's a bit more complicated. I don't think they're good or they're bad. I think the content might influence that outcome. The other part, which I think is related, is that I've been a psychiatrist now for almost 25 years, which is incredible to think about it. And until about 10 years ago, I had never asked a single patient. Here I run the busiest center in all of Canada. I'd never asked a single patient, are you lonely? I am convinced we've got a pandemic of loneliness out there. And the related issue with social media is that it is highly associated with loneliness. And the question comes up, did it cause loneliness? Is it the consequence of loneliness? And I think the answer is yes and yes. I don't think we really know. But I think that in some cases, and I've heard this firsthand from people, and I think it's true, that social media can also be a way to connect and build some resiliencies, build literacy, build resiliency, build a network, if it's healthy and all of that. But at the same time, we're also familiar with the fact that it can also be alienating, it can be bullying, it can be quite toxic and things like that too. So that's where the content comes in. So I haven't yet been able to get it on a bumper sticker that it's all good, it's all bad. I just think it's going to be content determined.
All I know is I'm really glad that social media wasn't around when I was a teenager or grade school. I could not be happier about that. Mean Girls is a real thing. And I feel for all the teens out there who are.
Well, can you imagine videos circulating and some of the things
No.
I was doing in high school? I know you guys are all angels, but I gotta be right. I'm glad there ain't no videos of me circulating around out there.
Oh no, my teachers are all surprised that I'm still here. So.
Yeah.
And are there more?
Important topics brought up there, and at the end, yeah, I think it's something we're going to have to keep watching about this phenomenon with social media, how young people react, and how that continues to influence the mental health of our of our country, but we have so many good questions in the chat. So I'm really excited to start going through them. One of our audience members asked, we have an acute shortage of mental health professionals, just trying to find a qualified psychiatrist or psychologist who have openings in their practice to take new patients is really hard. This person is commenting both in major cities on the East and West Coast. They're curious what is causing this shortage in our system and what can we do to change the situation so it's less hard for individuals to get help. And I'm just curious, because you all live and breathe this every day from your perspective, what some thoughts might be.
Well, I would be very curious in the Canadian perspective. Let me first give you what I think is probably some of the major parts here in the US. And my guess is they're similar, but I suspect Canada might be doing a little better than the US. So we have never had enough psychiatrists and psychologists to address mental health concerns in this country. And then a little thing called COVID came along and just magnified every problem that we had. And I think just it became so painfully clear how inadequately staffed we are. Now, I don't know if this is happening in your work environments, but I think COVID in a good way really forced people to say, I want to live my life differently. And that for me may mean I'm working part-time or I'm working virtually or I'm going to retire. And I am incredibly supportive of that. But the current situation is magnified by a recognition from, the Association of Medical Schools in the US that we don't have enough physicians. We're not producing enough of them. Medical schools are now starting to open up, but that's going to be another decade or so before those medical students become hopefully psychiatrists. So that's one piece. As a recognizing there are different types of providers that are getting into this space, one potential solution that I'm very supportive of is creating a new type of provider. So there are physicians' assistants or nurses that have elected to get additional training to become advanced practice nurses or become doctorates in nursing practice. And you can see this work group really starting to emerge in treating mental illness. So they are part of our depression center. They're part of many departments, and there are many free single sole practitioners working on their own. There's a different level of training, but there is a absolute need that they can fill in a very meaningful way. I think again, the benefit of COVID is we have developed a telehealth network in this country in a matter of months that would have taken, I think, had we not had COVID, years. Mm-hmm. And I think from Rural Minds is a great example of, and that's a partner of DBSA, of how we can really provide access to individuals living rurally in a way we've never been able to do before. I think the technology is here to stay, and that might help as well. But in essence, this has always been a problem, but the COVID has really magnified the problem. And I think COVID has created some potential solutions that if they can be scaled to a larger extent might be really helpful. How about in Canada, Roger?
Yeah, Mark, it's probably the question. I'm a psychiatrist who is professionally straddling both sides of the border and with my professional endeavors. And probably the most common question I receive across the country is about the Canadian healthcare space. Let me give you a statistic, which is not an outlier, but I think it really provides a lot of humility here. And that is, Canada is a relatively small country with respect to population. It's 34 million people. So the population of Canada is less than the state of California. So 34 million people live in Canada, of which almost half live in Ontario, Canada. In the province of Ontario, 80% of people with a serious mental illness cannot access a psychiatrist. 80% cannot access a psychiatrist. So we have a serious problem. Now, in the US, I would say the same thing as in Canada. It comes down to supply and demand. So let's talk about the demand. The demand for mental health is extraordinary. The demand, and I agree, Mark, the COVID has only ignited this further. The demand hasn't gone down. Thirdly, is that when you look at other areas of chronic medical problems, heart disease, diabetes, some forms of cancer, they're getting some wins on the board. They're getting lower mortality. They're getting decreased some of the consequences of the disease over time. There's not one mental disorder, not one, that's going down in prevalence. There's not one mental disorder that's showing overall improvement in the burden of the illness, the cost of society. All of our metrics are going in the wrong direction. That's it. So the demand is extraordinary. So 3 years ago, 2019, Health and Human Services said that the United States is shy 4 million mental health care providers. They came out 2 weeks ago. They're projecting 10 million shy by 2025. So we have never had, and we're never going to have enough bodies to see all these people. What's the solution? Well, one solution is to throw your hand up in the air and say, I'm hopeless, I'm helpless. The other solution is to say hello to Watson. Now, I'm referring to computers. And it would be unthinkable. Mark, I think you'd agree with me. Certainly when I trained as a psychiatrist, it'd be unthinkable that any kind of therapy could be offered by a computer. You had to see that warm, empathic clinician, et cetera, et cetera. It turns out that telehealth is not only effective and safe, but very acceptable to the end user for depression, bipolar, schizophrenia, substance abuse, post-traumatic stress, the list goes on. It is the only way we do it. I was at a meeting about 2-3 weeks ago. Someone would say, oh, we got to build more psychiatric centers. And I raised my hand. I said, I disagree. We don't need psychiatry Kmart. We need Amazon psychiatry. Psychiatry has to go to the patient. And Amazon is psychiatry of the future, not Kmart. And so that's how we have to do it. And it's not, do we want to do it? It's not, is it sexy? Is it the thing, is it kind of cool? It's not, that's not even the question. We have to do it. We have no way of filling this amazing gap and the demand is not going down. So, and we now have a use case, as they call it, a test drive, so to speak, that this can work. And we saw during COVID, it can. Now, frankly, I'm already hearing across the country, Mark, you're probably hearing this too, that some reimbursement might be compromised. They're not going to be paying as much on telehealth. And that's a real issue because a lot of people are saying to me, I don't want to do telehealth. I'm not getting paid as much anymore, stuff like that. But let's assume that that's a separate issue, but that issue has to be addressed. I think it is the future and it can be done. And, you know, Mark, you talked about the rural program. I mean, I was blown away that 75% of rural American counties don't even have a psychiatrist. So we have to do this. And I think it is the future. And I think that psychiatry was probably a bit of a laggard when it came to adopting telehealth. I think we had this notion we had to sort of sit with our patients and so on. And there's still a role for that, depending on how, you know, the needs of the patient. But I think this is the future. The supply and demand is outrageous. We need something like this. And Watson, the computer, I think, has stepped up to the plate.
Yeah, I think unfortunately, the benefit, there were some silver linings in the pandemic that we're talking about mental health more, that we're thinking a little bit more innovatively about the solutions. But yeah, it seems like we're definitely at an intersection of high need. There's another really cool question in the chat I'd like to get to in our last couple minutes here. Can you speak about the origins of the DSM's thresholds for diagnosis? What kinds of processes were used to decide these criteria? For example, the 4 versus 7 day threshold for hypomania versus mania. They seem really specific to this person who's asking this question, but this person has no sense of like the degree or the rigor of evidence that was used to kind of make these thresholds. So can you kind of high level talk about how we got the criteria that we have in the DSM?
Yeah, I'll take a first crack at it, Mark. I think that our colleague who's submitting that question is touching on a really important point. Let me tell you where they did not come from. They did not come from Moses. Okay, they weren't on the Moses. Okay, they didn't come from Moses. Okay, they came from a committee, and a committee that looked at the best science that was out there. And when you look at the best science that's out there, the science is asking 3 related questions. What are the most common symptoms that define mania? And what are the symptoms that don't define it? Secondly, how long do the symptoms usually last on average? And how much of this do you need to result in functional problems? And in fairness to the authors of the DSM, they have a unenviable task. Okay, this is unenviable. Okay, if we think that Democrats and Republicans are polarized, this issue is polarized even worse. Okay, it's hard to get harmony on this one. And they just got to find the right balance, that Goldilocks's temperature, that porridge, you get that just right. And it's not easy to do. And so they're taking the best of the evidence and they're trying to get that best fit. That being said, I see lots of people, I'm sure Mark, you do too, who have bipolar and they say, hang on, I don't fit what's in that DSM. I said, yeah, I know you don't, but based on my experience, you have your symptoms maybe only 3 days. Here it says 4 days. I know that, but you do have hypomania, and so on and so on. So, and that's where you want to talk to an expert who has that experience. We have to have fidelity to the DSM, but experts who work in the field kind of see the nuances that I think can help some people in some cases.
Well, I really love the metaphors. I think what I would just add to that is the group looks at all of the best available evidence and comes to consensus. And there's a lot to like about DSM. I think one of the advances that was very meaningful for the field and really had practical implications is recognizing the concept of mixed symptoms, meaning there can be depressive symptoms and manic symptoms at the same time, but all earlier versions only defined that within mania and never defined it in the depressive side for bipolar or in major depressive disorder for that matter. So I think that was a real advance, really recognizing the mixed piece. And that is so clinically relevant because it changes the way we practice. This is where we would never think about an antidepressant and would look more towards a psychotherapeutic intervention or a mood stabilizer, for example. I would like to see a day where psychiatry, mental health diagnoses are done in the way that a cardiologist diagnoses heart failure, or a rheumatologist diagnoses, rheumatoid, or an endocrinologist diagnoses diabetes. Yes, it's good to have criteria that are really based on a sign or a symptom or an interview, but I think from the standpoint of really speaking the same language worldwide, this is where biological markers must be part of diagnostic assessments in the future. This is a brain disease. We need brain markers to help us with greater diagnostic precision that then leads into more individualized treatment intervention. So there is a piece of the DSM that has a level of consensus decision making. One might say that is good, but I think there's a lot to be improved upon, particularly from the standpoint of really recognizing the neurobiology of these illnesses.
I cannot
a future day.
I cannot think of a more perfect question to end this session on misdiagnosis.
I agree.
So good one. Well, again, thank you both for sharing your knowledge and your time, and not just here, but with DBSA and our board and the work that we do, helping us review our content. So just a wonderful afternoon with you. Thank you, everyone who has joined us. Thank you, Hannah, for doing a great job filtering those questions. And I hope everybody has a wonderful, Wednesday afternoon.
Thank you, everybody.
Thank you, Maria.
Bye-bye.
Appreciate it.
Bye-bye.
Bye.
Bye.